If you all have seen my previous video, you all might know me. My name is Prerna. I'm an optometry student, and today I'll be talking about the examination procedure of low vision patients. So without much delay, let's get into the video. So basically, the normal aims and results of a low vision patient examination is quite different than the normal vision test, as because the first thing that we should notice is the general movement of the patient, like if he or she is very much affected by bright light, or if he or she can navigate themselves to the consulting room, do they have any physical infirmities like hand tremors or etc. So the second thing that we'll look for is the stability of condition, like if the patient have to change their low vision aids frequently, or the magnification power is changed frequently. The third thing that we'll look for is if the patient is aware of the condition or not, like what kind of vision loss they are having, is this acquired or congenital. And the fourth thing that we'll look is for the current visual status. Is the patient comfortable with the correct spectacles they are wearing, if they have the proper magnification power that is required from them. Then we'll see the education and employment procedure, as this helps us to decide what kind of visual aids do the patient needs. Then we'll look for the general health and medication, cause the systemic disease and all also affect the eyesight very much. And then the assessment part will be seen, like if the patient stays alone, or with whom the patient stays, like the partner or the family, or how is the daily life of the patient affected by this low vision. So now let's talk about the case history. This is the most important part, as it helps us to decide what are the needs and wants of the patient. So first thing that we'll check is the duration of the condition. We need to know from how long the patient is having problem with the current spectacles, or from how long basically they are suffering from low vision. So the most important thing is, what does the patient actually wants from the consultation. So after knowing all this answer, we move towards the visual acuity part. This is done for both distance and near. So let's talk about the distance visual acuity assessment first. This is done both monocularly and binocularly. The most important thing here is the room must be well illuminated, and then we give a target to the patient that is at a 3-meter distance. The patient is told to read. If they have any refractive correction, they are allowed to wear that. And if the patient is not able to read at 3 meter, we start reducing the distance from 3 meter to 1.5 to 1 and even 0.5. If still the patient is not able to read, we move to the hand movement, finger counting, light projection and light perception part. And now the same thing would be done for near vision testing. So while near acuity testing, we give a chart to the patient, but there is a paragraph type of things written. We don't give particularly words. There is a passage of line there, and then basically the patient is told to read from their normal reading distance, at what distance they are comfortable with. And in this way we just make the assessment of visual acuity for distance and near. So after the visual acuity assessment, we move towards the retinoscopy part. This is basically done in 2 steps, that is objective retinoscopy and subjective retinoscopy. So in objective retinoscopy, we give a large size fixation target to the patient, and if they are having nystagmus, loose lens rack is used, and even trial frames and loose lenses are used in the procedure. This is basically known as radical retinoscopy. And if the patient is having astigmatism, we choose to neutralize the meridians independently. So now let's talk about subjective refraction. The main advantage of doing subjective refraction is that the patient is allowed to assume their normal head position and the eccentric viewing technique. Even the examiner can see through the trial lens about the nystagmus and the squint part. And the main useful part is we can even use JCC, as it is very useful in determining the astigmatic correction. Now we'll be moving towards the contrast sensitivity part. This basically helps us to see the object in a very low contrast. This affects our day-to-day life if there is a problem in contrast sensitivity. And the checking for contrast sensitivity is important, as it helps us to decide what kind of low vision aids should be given. Basically, we use Pelly-Robson chart for the testing of contrast. After contrast sensitivity, let's move towards the color vision testing. This basically reveals the amount of difficulty the patient might be facing in doing all the tasks that requires color formation. For example, matching clothes, or recognizing the traffic signals. All these things would be very difficult if we have a problem with our color vision. So Ishara pseudo isochromatic color plates are used while doing the testing of color vision. So after all the testing, we'll move towards the visual field testing. This is basically done for peripheral and central. For peripheral, we can use manual or automated perimetry, and for central, we can use Amsler grid. And then we can do some glare testing. This can basically be done with the brightness acuity test, but this somehow doesn't quantify the effect that patient might be having. So for objective testing, we can take the patient out in a sunlight, and then we can observe the movements that the patient is doing, like he may be squeezing his eyelids or just using the hand as a visor. Like all this thing can be noted, and then we can check all the ocular motility and the binocular vision assessment, and finally we'll do some ocular health examination. So this was all about today. I hope I was able to explain everything properly. Please don't forget to like this video, share it, and if you're new to the channel, please don't forget to hit the subscribe button. Thank you.